so that we're on. And we're going to start talking about OCD, so obsessive compulsive behavioral problems. The first thing that I want you to do is watch a video about what OCD behaviors are, and then I'm going to go into the detail of them because we're going to talk into two categories. One is going to be the actual OCD behaviors, and then how it affects our kids with autism spectrum disorder. So let's start with this short video.
Hi, and welcome to another episode of Let's Talk About It, where we explore common mental health topics and answer questions. I'm Dr. Whitley Lassen, and I'm so excited today to be joined by Dr. Elizabeth McMahon. Dr. McMahon is a licensed clinical psychologist. She is an expert in anxiety, and she has a private practice in San Francisco where she treats clients. She's also the author of the book, Overcoming Anxiety and Panic Interactive Guide. Welcome, Dr. McMahon.
Thank you, Whitley. Thank you for having me. I'm delighted to be here to talk about OCD. It's such an important topic.
Today, we're going to be talking about obsessive compulsive disorder, commonly called OCD. We're going to be answering questions today about what OCD is and what it feels like. If you think you may be dealing with OCD, we encourage you to seek treatment from a licensed mental health provider.
Tired of typing tons of notes during class? There's finally a better.
So, Dr. McMahon, how would you explain OCD to someone?
Well, there are parts of the brain that get overactive in OCD and that keep sending off messages of danger, that the action you're taking is dangerous, that the thought you're having is dangerous. And so basically you get caught in a cycle with OCD of your thoughts telling you, oh no, what if this is dangerous? And as a result, you feel like I have to do this, or I have to not do that in a special way, or else something bad will happen.
What are some examples of the way that OCD can show up or how people might experience OCD?
So for example, I might be setting the table or making dinner for my family and suddenly look at the knife, have a thought or an image of stabbing my loved one, be so horrified that I would be afraid that I might act on that thought had some meaning, and I might put the knife down, I might take all the knives out of the kitchen and be afraid to touch knives. Or if I'm driving and it's a bumpy road, the thought might pop into my head, maybe I've hit somebody, and I might feel compelled, like I have to turn around and check and look. Or I might worry that I haven't cleaned sufficiently, even though I've cleaned my normal way, and worry about germs or illness. We're not talking about COVID precautions that are reasonable. We're talking about way beyond what actually makes a difference. And sometimes OCD shows up as a need to have things in some kind of perfect, rigid order, a feeling that things have to be just right or else something is terribly wrong. So OCD can show itself in a number of different ways, but it's the same underlying problem and process.
It sounds like OCD is an anxiety problem. And we talked before about the cycle of anxiety. How does OCD fit into that cycle?
I think OCD fits very well. There are two triggers that can trigger OCD and distress that I think are particularly relevant for OCD. One is genetics. Anxiety, including OCD, tends to run in families. You may simply be born with a nervous system, a brain that's more likely to develop this overactivity. And a second factor is making a demand for perfection, seeking certainty or guarantees. Both of these can make it more likely that the brain gets a message that something is wrong, something is dangerous, so that your body feels tense, anxious, nervous, scared, And your thoughts turn to what's wrong? What if something happened? And as a result, you start to take actions to try to prevent the danger, to try to be safe. You try to stop the thought and fight it or to avoid it. And unfortunately, this, what if something happens? Oh, I have to do this or else, creates a vicious cycle that feeds on itself. Because in OCD, the alarm system in the brain is stuck, you can repeat this endlessly. And giving in on the distress and the false alarm of danger, it's a lot like paying off a blackmailer. It may give you some momentary relief. The blackmailer goes away for a minute, but he always comes back. And a lot of times he wants more and more. He's never satisfied.
Check this out. I'm going to show you how I afforded this.
In the mental health world, how is OCD defined?
So OCD is considered a mental health disorder where a person has what are called obsessive thoughts and carries out what are called compulsive mental or physical actions. So let me talk about what we mean by that. By obsessive thoughts, we mean upsetting, distressing, sometimes horrifying thoughts or images or urges that come into your mind, even when you don't want them, and that keep repeating and returning. These are what we call obsessive thoughts or obsessions. Now, these thoughts can cause so much distress that you feel like you have to do something to make them stop or to prevent something awful from happening. And because you feel like you have to, because you feel compelled, these responses are called compulsions. And compulsions can be physical actions like cleaning repeatedly, washing repeatedly, counting, checking, going back and repeating actions, or they can be mental actions that you just carry out inside, like reassuring yourself or counting silently or repeating words. You can feel compelled to repeat what you've done over and over, even if you've already done it several times, and even if on some level, you know it doesn't make sense.
What are some common examples of obsessions and compulsions?
Well, some very common obsessions are worrying thoughts that intrude into your mind about germs, things aren't clean, worries about purity, worries about things being right, they're not being right in some way. There can be obsessive thoughts that things have to be symmetrical or perfectly ordered. They can also include personally taboo and upsetting thoughts like sexual or blasphemous thoughts or images or thoughts of causing harm. Compulsions, the actions that people feel compelled to do because of these obsessive thoughts, some of these actions can seem to make sense and do make sense if they're done for a realistic reason and to a realistic degree. For example, cleaning after cooking makes sense. Washing your hands after you've been working in the yard makes sense. But OCD symptoms, the compulsive actions, don't realistically prevent harm, and they're done over and over and over. So some common compulsions are hand washing, maybe to the point where your skin is cracked and broken, cleaning repeatedly or in some very rigid way that's never maybe quite good enough, putting things in order, not a reasonable order, but it has to be an absolutely perfect, specific order. Checking things. You don't check that the oven's off once, you have to check repeatedly, or checking that the door is locked repeatedly. Counting is another common compulsive action. As you can see, there's quite a variety.
What is happening in our brain when we're dealing with OCD, or what does an OCD brain look like?
That is a fascinating question. And through the miracle of modern technology, we can actually watch our brain and we can see that certain areas are overactive in OCD. And you can see in this, what's called a PET scan, you can see certain areas of the brain that are more brightly lit, showing that they are more active than normal. So in other words, something's happening in the brain that is not your choice and not your fault. But parts of your brain are sending off these thoughts, almost like shooting out sparks that start fires. And some brains spark bigger, more frequent fires. And then because the thoughts are upsetting, you feel like you have to do things to stop the thoughts or reassure yourself. And that's like putting fuel on the fire.
If you're interested.
Okay, so this was a little video that talked about, what actually OCD looks like. So now I'm going to go over strategies that can be used, and I also sent you a chapter. The chapter that I sent you is from this book, which is called as Taking America Off of Drugs. It is by Stephen Ray Flora, and I really like this book because this talks about other disorders also. It talks about how to deal with ADHD. It talks about, specific phobias, ADD, depression, schizophrenia, and it also talks about eating disorders, anorexia, bulimia, and other things that can be treated with OCD, with therapy. So let's talk about, just give me 1 second. Let's talk about what OCD is. Do you guys have anything to tell me or talk about, or any comments on OCD? Anybody has a client with OCD? Okay, so let's keep on going. People given the label obsessive compulsive disorders, or OCD, they have excessive, unwanted, intrusive, repetitive thoughts, and they engage in excessive, repeated, ritualistic behaviors. So basically, they're repeating their behaviors again and again, and these aversive obsessions and compulsion behaviors can become so excessive that the person who suffers from them is unable to function normally in the society. And in the video, they gave you an example of somebody washing their hands again and again. And after they wash their hands again and again, they can be to a point where they start bleeding out. There is also a mention of self-injurious behaviors, taking a shower 12 times a day, washing your hands 50 times a day. So these are the kind of things that an OCD behavior looks like. So now, basically what happens is that whenever you go to a psychiatrist or a psychologist and they say that, hey, you know what, your child has OCD. So what they do is that they try to put the kids on SSRI medications, which is supposed to do a whitewash for the brain, which means that reset the brain so that the brain doesn't think about these ritualistic behaviors. And, it's supposed to do like a drug whitewash. But having obsessive thoughts and engaging in compulsive behaviors are things that people do all the time. These are learned behaviors sometimes, but people who are labeled as OCD have this compulsion to do something, which then becomes a ritual. So now this is how we have to think about it. Obsessive compulsive behavior is something that a person obsesses over because that is what their brain chemistry is telling them to do. And then after that, they have a compulsion to do it, and then it becomes a ritual. Because the obsessions are aversive, the sufferer tries not to have them, but the more the person tries to suppress the thoughts, the more intrusive they become. So when you try to suppress your thoughts and there is an OCD behavior, then the more intrusive these things, they start to begin. So the more you try to do it by yourself. So for example, if I have OCD and I have these feelings, I have to check my lock again and again. And if I try to suppress them, it will become more aversive for me, more intrusive for me. Thus, behaviors meant to escape the obsession or avoid the perceived disastrous consequences are performed, and rapidly they become rituals and compulsions. So what happens is that they become so ritualistic, so, they become so intrusive that you try to do them again and again, and they become like a compulsion, like you have to do it. And then as that happens, you try to, they become more and more worser, and they become ritualistic. So that is for a person suffering from obsessions, the compulsive are believed to serve the purpose of to be functional. So whatever compulsion they have, that is the function of their behavior. So when you see that that compulsion is a function of their behavior, so that is a problematic behavior. So you're going to be using different behavioral strategies to eliminate that behavior. The compulsion escape or avoid the obsession catastrophic consequences. Technically speaking, the compulsions are maintained by negative reinforcement. Often the compulsions became so entrenched that the original real or imagined reasons for engaging in the ritual may be forgotten. So what happens is that in the beginning, it just starts as an obsession or a compulsion that they're having. And then they become so ritualistic that they actually forget why they started it, and it keeps on happening and they keep on doing it. Now, persons labeled with OCD, cleaner, are obsessed with dirt, germs, sickness, or with compulsions that they have to clean. If they don't clean, they're going to get sick. Likewise, so what happens is that this is what their ritualistic behaviors are. So there was an experimental model that was done a couple of years ago, almost 50 years ago. And in that, what happened was that, there was a therapy that was done, which was called as exposure therapy. And the next thing that was used was response prevention. And what it was seen was that in experimental logs, this became very successful. And the people that were doing those ritualistic behaviors, when they were exposed to those conditions and when they wanted to do that certain behavior and they were stopped and redirected to another activity or something like a DRA, differential reinforcement of alternative behavior, it became better and better. So basically, this was something that was used, which again, you guys have to remember, this is called as exposure and response prevention. This was used to eliminate the compulsive behaviors of the organism that this experiment was done on. So the most widely studied behavioral approach for OCD includes exposure to the vivo and then ritual prevention. This method, the patient is brought into a contact with a feared object. So for example, toilets, door handles, stoves, and door locks. And the patient is asked not to engage in this ritualistic behavior. Exposure treatments allow patients to face anxiety-provoking materials, and then blocking it is something that happens. And blocking treatments halt patients' behavioral or mental ritual through stopping aversion therapy. And this treatment should habituate obsessive fears and prevent rituals that interfere with the anxiety. So again, you bring them to that place where they are having those obsessive compulsive thoughts. And in that situation, whenever they try to do their obsessive compulsive behavior, you are doing a response interruption and you're stopping their response and not letting them do that. You let them do something that is different, which is an alternative behavior. And once they do an alternative behavior, they are reinforced for that. So in this manner, what happens is that because you're exposing them to that fear, their fear starts to die out. And then you're redirecting their behavior to something else. And that is where your behavior is modified. Now, in some examples or in some cases that I researched and I studied, what I found out is that sometimes this doesn't work because there are going to be a lot of severe cases. And in those severe cases, it's not the exposure therapy and the response prevention is not going to work. So in those cases, what happened is that there was a pharmacological model that was used. And in that pharmacological model, the medications that were used were it was a tricyclic antidepressant, which is clomipramine. And then Prozac was used, which is fluoxetine. And then clomipramine, what was seen was that if you gave Prozac still worked a little bit better as compared to the clomipramine, because what happened is that the behaviors relapse. But always remember that when we are doing when we are doing these kind of behaviors, when we are trying to work with them, we also have to give them medication And along with medication, we have to do the exposure therapy as well as the response prevention therapy. And this is what has been used by a lot of psychiatrists. However, adding drugs does not increase behavioral treatment effectiveness all the time. Okay, so you have to monitor it very closely. Sometimes, medicine alone is not going to work and you have to always add behavioral treatment. But sometimes they both might not work. And in those situations, you have to look for other alternatives. You cannot just drug people with obsessive compulsive disorder. You have to use behavioral treatment. There are tons of articles that are available for behavior treatment of individuals who have OCD. So there was another way of finding out. You can always do a PET scan, which is going to show that how the brain is working and how the obsessive compulsive behaviors, they are happening in the brain and how certain areas of the brain, they get lit up. Now let's go and talk about autism. So when we talk about autism spectrum disorder, what we have seen is that the kids, they are engaging in ritualistic behaviors. So a lot of our kids that have autism spectrum disorder, they also have ritualistic behaviors. So these ritualistic behaviors that they're having, they are called as, these are also called as OCD behaviors, but there are two types. One is the stereotypical behavior, and the other is the actual obsessive compulsive behavior of opening and closing the door again and again, of turning off and on the lights again and again, washing your hands again and again. So these are two different types of behaviors that occur. So one is called as the higher order repetitive behaviors, and the others are called as the lower order repetitive OCD behaviors. The lower order repetitive behaviors or OCD behaviors are the stereotypical behaviors, which could be self-injurious behaviors, which could be like, anything that is flapping their hands, twirling their hair, even trichotillomania sometimes where, they're pulling their hair out. So these are all the things that are happening. These are the lower order obsessive compulsive behaviors. So always remember that the lower order obsessive compulsive behaviors can always be treated by everything that we were taught in the IBT class, which is that you guys have to first of all find the function of the behavior. After you find the function of the behavior, you are going to look into different researches and different treatments that are out there. And those are the things that are going to be used to treat those behaviors. So for example, when you find out the function of the behavior, you're going to use things like response blocking and differential reinforcement of other behaviors. And then there are other things that you can use, which are consequence-based interventions, which is that you can change that behavior with reinforcement, with punishment, with extinction. And then there are antecedent manipulation strategies that can be used. And the antecedent manipulation strategies are strategies like, something to do. Okay, let me ask everybody over here. The people that are sitting over here, do you guys know what antecedent manipulation strategies are? Let me see who will answer this. What are antecedent manipulation strategies?
मैम उसमें
Yes, Anji, yes, I'm listening.
मैम उसमें ये होता है कि हम पहले से कोई ऐसे प्रिवेंटिव मेजर्स कर लेते हैं कि उसमें शायद वो बिहेवियर हम होने नहीं देते।
बिहेवियर नहीं होने देते, या हम इस तरह से एनवायरनमेंट को हम एनवायरनमेंट को इस तरह से मैनिपुलेट करते हैं कि वो बिहेवियर ना हो सके, राइट? सो कैन यू गिव मी एग्जांपल्स ऑफ
बिल्कुल
एंटीसीडेंट स्ट्रेटजीज?
मैम फॉर एग्जांपल इफ द चाइल्ड इज टर्निंग द डोर हैंडल अगेन एंड अगेन or deadlock, we can take out that.
Okay, and what kind of a
ऐसा हो
procedure is
सकता है?
that? Is that extinction or response blocking?
मैम इट इज एक्सटिंक्शन, क्योंकि हम वो बिहेवियर उसको जो रीइंफोर्स हो रहा है उसको हम वो चीज हम ले रहे हैं उससे, और वो नो उसका वो अब जो है वो रीइंफोर्समेंट उसको वो नहीं मिल रही है।
Right, absolutely right. Okay, anything else? So functional communication training भी आ जाती है इसमें, antecedent manipulation में जो आपने अभी therapy बताया, जो अभी मुझे बताया ना, that is a consequence based intervention, which is like जो उसका consequence होगा उस पे हम उसको reinforce कर रहे हैं या punish कर रहे हैं या extinction कर रहे हैं. लेकिन जो antecedent manipulation strategies होती हैं ना, उसमें आप non contingent reinforcement भी दे सकते हैं, आप उसमें जो है वो environment को modify कर सकते हैं. You can use Premack principle, which is the behavior momentum strategies. You can also use non-contingent reinforcement. So these are the kind of things that you can use for antecedent manipulation strategies. And this is also something that you can use for OCD. Now let's listen to this little, there is a little over here where that talks about how to treat OCD and what are the, what is the behavioral therapy, and then I'll go further.
Many of us have our own unique habits and rituals that we carry out on a daily basis, like carrying around a lucky penny or avoiding cracks on a sidewalk. But for people with obsessive compulsive disorder, those innocent rituals take a different form, often causing distress and interfering with daily activities. Obsessive compulsive disorder, or OCD, is a severe and often debilitating neuropsychiatric disorder that affects approximately 3% of the population. Due to the nature of its symptoms, it's largely depicted in a stereotypical manner in the media, and in everyday life, people often refer to their overly meticulous behavior as OCD. But being overly neat, specific in the way you do things, and wanting your house to always be spotless does not mean you have OCD. OCD is characterized by severe, persistent, and unwanted thoughts, urges, and images that come in the form of obsessions and compulsions. Obsessions are extremely disturbing and pervasive thoughts that interfere with everyday life. Compulsions are ritualistic behaviors or mental acts that are performed repeatedly in an attempt to relieve the anxiety or stress that obsessions tend to create. Compulsions sometimes, but not always, follow the obsessions. The relief experience from the repetitive compulsions is relatively short-lived and tends to return if the obsessions persist. Once OCD develops, it is usually reinforced through a positive feedback cycle where compulsive behavior alleviates the stress and anxiety that obsessions tend to induce, but in turn, reinforce the compulsive behavior. For example, an individual with OCD may feel anxious about certain diseases and can obsess about getting sick. To alleviate this distress, they may feel the need to wash their hands excessively or avoid contact with certain objects. The repetitive washing or avoidance will make them feel better in the short term. However, when they feel the same distress again, they're more likely to repeat those actions that reduce their stress. Individuals suffering from OCD can undergo two types of treatments: medication, such as selective serotonin reuptake inhibitors, and therapy. One of the most common forms of therapy for treating OCD is cognitive behavioral therapy, or CBT. CBT is a short-term, goal-oriented psychotherapy that is used to teach individuals how their thoughts, feelings, and behaviors work in tandem and develops personal coping skills that can be used to change negative patterns of thinking and behavior. To help explain what CBT is, we arranged an interview with a physician that is trained in CBT. The C stands for cognitive, which refers to the fact that people have thoughts and interpretations and images in their minds in certain situations. It's how you think about things and perceive situations that dictate the kind of emotions that will follow. In anxiety disorders, such as OCD, emotions are one of anxiety and distress, and are mediated by the kind of thoughts that people have. In the case of OCD, the thoughts are obsessions, which are the cognitions that we need to work on in CBT. The B refers to behavior, and the therapy focuses on changing aspects of the behavior that are dysfunctional and are maintaining the anxiety state. The therapy comes up from the point of view that the way we think about things and the way we behave around them will dictate the anxiety that we feel in those scenarios. Anxiety is maintained by the kind of distorted thinking that the patient has. If you break the cycle of distorted thinking and distorted behavior, we can get a breakthrough in the level of anxiety. The person starts to realize that they can enter a situation that made them anxious in the past and stay in the situation thinking more rationally. The patient's role is to stay engaged in the therapy. In order to break the cycle, the patient has to do a lot of work on their own. The work is done between sessions and is based on the idea that if you don't practice a skill, you're not going to learn it very well. CBT is a skill or a set of tools that you develop for yourself and use when you need them. CBT takes about 12 to 14 weeks. The first few weeks are usually about gathering information about the person's particular manifestation of anxiety and doing psychoeducation around it. We gather information about the person's own form of OCD, what are their rituals, and if they have obsessions that bother them. Then we create a hierarchy of things that cause them distress. This is a tool that we use for the rest of the sessions. First, working with items on the hierarchy that don't cause as much stress, and when they become comfortable, move on to slightly more distressing situations. It's a graduated approach with dealing with the hierarchy. The person becomes more used to the concept of what they have to do. The patient becomes aware of when they are obsessing instead of doing it automatically. They realize that there's another way of dealing with the anxiety, that what's being taught in therapy is actually working, and can use their past success of overcoming their obsessive compulsive symptoms in other situations. Sometimes CBT involves medication that can help at the same time while doing therapy. CBT is not for everyone. Individuals have to be very motivated to change because it is hard work and causes a lot of distress. In this therapy, you have to feel more distressed before you start feeling less anxious. Not everybody's ready to do something that difficult, and not everybody has the time. It also can't work for people too severe in their presentation of OCD, as their anxiety gets in the way of agreeing with what they need to do. They find that they are arguing and bargaining with almost everything they're asked to do, and are too anxious to complete the homework. Those people are candidates for medication, which would tone down the anxiety level so they can engage in the therapy.
Okay,
And can you
sorry. All right, guys, let's go further. So now there's another article that I have over here, and this article also I'm going to share with you guys because this is a very, very good article. And what this talks about is, it talks about a clinician, who has very little knowledge about how to treat a child with OCD is not going to be able to work with them. So like, for example, I had a kid recently that joined one of our branches, and, they had gone to every psychiatrist, every psychologist, and they couldn't find what is wrong with their child. When he's going for ABA therapy, he's flying through it, but then he also had OCD. And the way that the therapists were dealing with it wasn't the right or the correct way or the correct manner. So now what happened is that, you have to understand that that's why supervision is very important under a BCBA, under a BCABA, or under, so this supervision is very important under IBA, QABA, whoever you're working with, because those are the people who are going to tell you how to work with those kids. So for example, if you're doing a regular ABA therapy session for a child, with your ABLES or behavior management strategies, you won't be able to come out with the same outcomes as are going to come with when you know what the disorder is and how to work with it. So basically, what they talked about is that there are two different kinds. One is the lower order repetitive and restricted behaviors, which are classified as OCD in autism spectrum disorder, as well as there are the higher order ones. The higher order ones are turning the lights off and on again and again, turning the switches on, off and on again and again. Okay, so when we talk about a framework for behavioral and psychosocial intervention, an important distinction that can be made in the autism intervention literature is the differentiation of the comprehensive treatment models and the focused intervention practices. So when you're talking about the comprehensive models, that is the Denver model, which is the Lovaas Institute and the Teach Institute. So everything that you're doing like Lovaas and Teach, these are all called as the comprehensive treatment models. So when you're working with a child who has OCD, always remember that you can do comprehensive models, but you also have to do focused intervention practices. And focused intervention practices are those intervention practices that are only chosen for OCD. And then there is a behavior plan that is made for it. And then you treat it according to that disability and disorder. Okay, so CTMs, and which is the comprehensive treatment model, and the focused intervention model can be designated as evidence-based practices for these kind of issues and situations. While the bulk of evidence for specific CTMs and FIPs, which is the comprehensive treatment models and focused intervention models address the area of communication, social play, cognition, and independence, there is evidence that the specific behavioral teaching strategies for OCD are going to be effective. So all the people out there, all the therapists out there, along with using a comprehensive model, you should also use the focused model for obsessive compulsive disorder. The focused model is going to be the exposure therapy, the response, redirection therapy or the response blocking, the differential reinforcements, the interruption, and the redirection. Now, when we talk about, so this was the, now let's talk about the lower order repetitive behavior. So for the lower order, repetitive behaviors or the OCDs, which are the stereotypical behaviors, again, you're going to use behavioral interventions, which are called as consequence-based and antecedent-based, and we just talked about those. Some of the consequence-based intervention strategies that have been used to treat these behaviors, which are stereotypical behaviors, which is suppose repetitive vocalization, self-injurious behaviors, pacing back and forth, flapping your hands. These are all behaviors that can be treated with physically or verbally blocking the individual from engaging in the behavior, response interruption and redirection strategies, removal of positive consequences when the stereotypic behavior occurs, reinforcing other behaviors the individual displays instead of the problematic behavior. So again, DRA. Also, we can use functional communication training so that the child can let us know what he wants instead of having the behavioral issue. So a functional communication training is a multi-component intervention that involves teaching the individual an appropriate communication response that can be used to obtain the same reinforcer as the inappropriate behavior. When you're doing antecedent-based strategies that have been used to treat stereotypical behaviors, they include providing the individual visual or verbal cues, forewarn him, do prompting, all these kind of procedures that are going to be used for stereotypical behaviors. Now, I want to go back to the treatment of higher order behaviors. So what are the higher order behaviors? Higher order behaviors are going to be for OCD that, turning the fan off and on again and again, flipping the lights, opening and closing the doors and things like that. So as with lower order repetitive behaviors, as ABA perspective has informed much of intervention research on higher order repetitive behaviors, one exception to this is that the intervention research on OCD in individuals with ASD, which can trace some of its roots to cognitive behavioral therapy. So yes, there will be, for the higher functioning of them, we can use cognitive behavioral therapy. So what we are going to use is cognitive behavioral therapy, which includes exposure therapy and then the response intervention and redirection strategies. So anything that you guys do or anywhere that you work, you always have to follow it like ABA, because now you're all ABA practitioners. And as you're all ABA practitioners, you should be working under the supervision of a BCBA, a QBA, an IBA, and those are the people who should guide you what to do and what not to do. So for all the OCD behaviors that are like higher order behaviors, you're going to use exposure therapy and then response preventions. And also we can use a pharmacological medications with them, but they are always going to work in a package with each other. They are never going to work separate of each other. And the second thing that we're going to talk about is for stereotypical behaviors, which is the same kind of treatments that you have used in the past. Okay. So which is, response blocking, extinction procedures, you can do redirection procedures, but everything has to be done in a systematic manner. The first is going to be taking baseline data. After you take baseline data, you're going to do like a functional, you're going to get indirect assessments. You're going to topographically define the behavior. Then you're going to do direct assessments. After you do direct assessments, you are going to do research. You're going to come up with research articles, and with those research articles, you are going to be able to, do what is better for the child. And this is how you go about OCD. So never treat OCD just with a comprehensive package, because it's not going to work. There are other strategies that you're going to have to use, which is a focused intervention. And the focused intervention is only going to come when you do your research, when you know what to do. So even if it is pharmacology that you're using, which is medications, you also have to use behavioral treatments with that. And that's about it for me, but I am open to ask you guys asking me questions, and then I can answer some scenario-based questions for you. Any questions? Do you have any clients who have OCD behaviors? Okay, so what I'm going to do is I'm going to send you the article that we just read. So go through that article, go through the chapter from the book, and then if you have any questions, just let me know. I will also share the recordings of this, today's CU event with you guys. And in a little bit, I will give you a schedule of how we're going to go forward with the rest of the 3 CUs that are left, okay? Any questions, any comments? Okay, guys, you have a very good weekend. Okay, good job. Bye-bye. I
Thank you,
will see
ma'am.
you tomorrow. Stimming is an OCD behavior. Yes, it does come under OCD. And that's what we talked about. Lower function, lower order and higher order. Lower order is stimming behaviors. Higher order is, the ones that like washing hands, opening doors and things like that. Okay, guys. So I will see you tomorrow.
Thank you, ma'am.
Bye.